Welcome, everybody, to Wu University's Glaucoma Innovation Series. And I am so excited for this very first lecture. And we have such an amazing speaker kicking off this lecture with the glaucoma update. And my name is Dr. Stephanie Wu. I am the host of this evening, and I am the founder of Wu University. And these are Dr. Timmins' financial disclosures. And it is my pleasure to introduce Dr. Jim Timmins. He is a graduate of the Ohio State University College of Optometry, and he completed his hospital residency in 1979 and then served as chief of the optometry service until 1985. He has written over 200 publications on glaucoma, dry eye, cornea, and external disease, as well as refractive surgery and new technologies, and he's received numerous awards for his service to the optometric profession. In 1999, Dr. Timmins was awarded optometry's top educator, and he was selected as one of the top 10 clinicians of the decade. In 2002, he also founded the National Glaucoma Society, and that provides educational and clinical development services to primary care clinicians worldwide in the area of glaucoma management. It's a society that I really love. I'm always getting new information. I love their newsletters, and anybody that's on here tonight, I'm sure, loves glaucoma information, and I would highly recommend checking out his site. On top of that, I have personally seen Dr. Timmins lecture many times at many different meetings. He is excellent. He was the perfect person for us to kick off this glaucoma series. And I'm so thrilled and excited to announce that we have over 1,600 people that have registered for this evening's event. And I'm sure it has mostly to do with Dr. Timmins and his amazing education that he's going to present to us. So thank you, Dr. Timmins.
Stephanie, thank you. That was such a lovely introduction. I'm not sure that I recognize that person, but I will certainly do my best to live up to those kind words. To all of you, I cannot tell you how enjoyable it is to spend a Tuesday night on the East Coast and wherever you are in the United States together. This lecture is one of my very favorites. It's a compilation of all the things that I do day to day in the office, the people that I've been able to do research with, some of the individuals I admire the most in the glaucoma world. We're going to cover a wide variety of topics tonight, sort of a meritage, if you will, of glaucoma. We're going to talk about some of the greatest literature of the last few years that really impacts day-to-day practice. We're going to discuss new technologies within the space. I would like to talk a little bit about a unique subject, which is ganglion cell technology and where it's evolving to, which I think is rapidly taking over RNFL and its role in the combination analysis of our patients in both glaucoma and other diseases. And then we're going to move into some new devices that I think are fascinating and have revolutionized my practice, both prior to COVID and during COVID, and then subsequently move on, maybe if we have some time, into the MIGS procedures that we're currently doing. We have certainly probably the most active private practice I'm aware of on the East Coast. We're doing well over 100 surgical glaucoma procedures a month in my office, myself and my partners. So we'll do what we can tonight, but I think all of this should serve as an interesting platform for you to apply to your practice and your patients when you go home. Part of the many reasons that I love the profession is it to allow me the opportunity to travel and do things. This is myself and my most senior daughter in Paris a few years ago at a lecture. And this is myself and my youngest daughter at the top of the mountains in Switzerland at another lecture. So I love the profession for what it's allowed me to have. And this is where I live in Connecticut. That's the ocean. That's the Atlantic Ocean. Long Island Sound, to be accurate, but it's still the Atlantic Ocean. And that's about a half a block from my house. So I do have my coffee there sometimes and basically think about not going to work after watching something that's beautiful in the morning. So let's move on to the subjects at hand. New concepts in diagnosis and treatment. There's so much going on in glaucoma today. You know, 10 years ago, I would have given this lecture, and I think you might have been disappointed, to be honest, that the material was pretty much same old, same old. 10 years later, glaucoma could not be more exciting. There's an avalanche of the material. We're going to try to cover as much as we can tonight to give you a perspective about all the unique and I think remarkably important developments that are taking place now and into the future. First and foremost, we'll talk a little bit about OCT versus visual fields and the relative capture of new glaucoma patients and how you can use both of those together to maximize your skill set. Corneal hysteresis in glaucoma suspects, a really new paper by Felipe Medeiros. SLT as primary therapy, the light study, I think, has brought to the forefront probably the most important disruptive change in initial therapy we've had in a long time. And then the repeat SLT and then OCTA and glaucoma, which I think is an interesting subject, but not particularly relevant to us today, but maybe into the future. This is a slide from Sanjay Osrani, a lecture that he gave on Cape Cod at one of our many, probably our 8th or 9th glaucoma symposium. We're up at 19 now. And this is true about all the devices we use, is that the best brain in the system is the one that we own. The devices are simply there to acquire data. Our job is to interpret the data. The device doesn't interpret the data for us. This is a piece of work by Don Hood. I'm going to preface all of this discussion about ganglion cell with this. Don Hood is the brightest mind I know in anatomy and visual fields. In the United States, he has basically built the nomograms for most of the systems and the algorithms for analysis. This is his work on ganglion cell anatomy. He was the first to really derive this. As you can see, there's this really notable difference in sensitivity of ganglion cells to glaucoma damage. The inferior arcuate bundle with that very clear step is much more vulnerable inside the macula than the superior bundle. And so what we see is a really fascinating change in the GCC readout. For those of you who are not using GCC routinely, I would offer the following recommendation. I don't think it's worth doing an RNFL if you're not going to do a GCC at the same time. Unless a patient has limitations of macular function like AMD, DME, VMT, VMA, macular holes, those types of issues, that defaults the GCC. If the patient has normal macular anatomy, the two of these together are such a perfect match to make the diagnosis. This is what's called a wiper defect. As you can see, it has that beautiful inferotemporal sensitivity cut that Hood originally diagnosed, just sort of derived and is given to us. And by the way, Don Hood has a phenomenal website if you want to do a little bit of deep dive into glaucoma. His lectures on interpreting OCT, I think, are some of the best I've ever heard. So, and it's a free website. You can look him up online. The reason this is important is in his original work back in 07 with Drazo, or 2011 with Raza, and then prior to that, 27 with Drazo, what they noted was that you'll see ganglion cell loss before you see RNFL loss in about 25% of the patients. And so when I see a patient with a ganglion cell loss that's not reflected in the RNFL as a clear indicator of disease, or if the visual field's normal on a 24-2, I will then go back and I'll look at the GCC and say that's an abnormal GCC with a clear wedge. This patient has glaucoma. Let's go a little further. I'll do the next level of investigation involves switching from a 24 to a 10-2. About a fourth of the patients, approximately, will end up having a near fixation loss that you didn't see on 24-2 because the separation of the 6 degrees of the target elements is too large for you to physically find that defect. You need a more dense analysis, which is the 10-2. This becomes a critical element in patients in the office where you're very suspicious, play together perfectly to make a diagnosis. So this patient looks like they have a pretty normal OCT. All right. The problem is that the OCT has a fundamental flaw, and that is that it is a extra large nerve. So it's a supersized nerve or a megapapilla. Megapapillas were not included in the original algorithm analysis for the disease, for the glaucoma package on any of the devices. They use normal sized nerves between about 1.8 and 2.2 on average. A little bit of variation, but not much. So this nerve's a megapapilla. And what happens is, if you can imagine, this is your nerve size for normal. Your T-SNP circles that nerve size, as you can see right there. And in a normal nerve, the T-SNP is displaced 1.71 millimeters from the center of the optic nerve, which is based on the edge of the Bruch's membrane opening, which defines the nerve size for all OCTs. So that BMO becomes the centerpiece for the analysis. That 1.71 is standard in the industry. All of the data points and the analysis points are set to that. So as a result, when the nerve is extra large, instead of having the T-snip be this far from the nerve, now it's this far. And that distance decreases the relative analysis sensitivity. And what occurs is when you get closer to the edge of the nerve, we all know the fibers heap up as they elevate and then enter into the nerve. And as a result of that, you get this very unique misstatement of the nerve status. This could well be a glaucomatous nerve. What's reading is that because the nerve's so large, you're getting green disease. And the way to differentiate that is do a GCC. In this case, the GCC clearly shows damage, whereas the RNFL was normal. I see this, I'm doing a 10-2. You might even find this on a 24-2, but you might be confounded by the fact that the two are appositional. You have a loss, but the retinal nerve fiber is saying it's normal. Do the GCC. Conversely, in a patient with red disease, just the opposite, you have this unique situation where, let me pull down the toolbar here and get out of the way. You have this unique situation where the nerve is too small. Now, this is a normal nerve, and now you have a nerve this big, so the T-snit is displaced far into the retina, where the nerve fiber layers are naturally lower in volume. And as a result of that, you end up in a situation where you'll see an eye that's flagged red and looks very glaucomatous, but in fact may be completely normal. If you run the GCC in those patients, typically it's going to be a normal GCC and a visual field, which also should be normal, which should tell you that this patient has red disease. You still may be suspicious, you should be if there's other indicators, but this is a patient where you do serial OCT over time to look for change on the GPA or the glaucoma progression analysis, as opposed to waiting or trying to make a decision on an initial eye. I mean, I've seen patients with completely normal eyes that have nerve fiber layers of 63. Why? Because they have a 1.2 optic nerve, and you're reading so far out into the retina that you have a existent thinner level of fibers at that point. So relatively speaking, GCC and the RNFL are partners in life, and they should be used constantly together. Oops. There we go. So this is an interesting paper. This is by Satoon. Another reason the GCC is critical, colleagues, is the GCC leaves the eye and enters the cerebral cortex. The analogy I would give you is if you're doing electrophysiology, the ERG is based in the retina. The VEP is based in the brain. Same thing with GCC versus RNFL. RNFL is a retina-based analysis. The GCC is a cortically based analysis. If you doubt that there's a relationship between GCC and the cortex, take a patient who's had a notable stroke and give it 6 months to a year, and you will frequently find that when you do the GCC, the patient will have a beautiful vertical cut of the GCC that matches their hemifield or their quad loss. Even though that may have taken place in the occipital cortex, it advances the GCC loss to the LGN, and then the LGN up to the optic nerve. And so what you're finding is this Wallerian forward progression of degeneration is a common event, and the GCC can show you posterior to the globe damage, not in the globe at the optic nerve head, but in addition, posterior to that damage. To me, the biggest component is not that CVA patient or a patient with blunt trauma and subsequent cortical damage, although that's useful. I'm much more inclined to use this device for neurodegenerative disease, MS, Parkinson's, and Alzheimer's. And there's clear evidence in the MS field and the AD field that this device is probably the first weapon to be able to look at changes, because when the optic nerve is damaged in those diseases, and there's sort of characteristic changes that we have with those, when it's damaged, it never changes. It doesn't repair. It stays that way forever. The RNFL is usually unchanged. The visual field may go down if the vision goes down, but when vision returns, it comes back. Even color vision generally comes back. RNFL, or the visual acuity, comes back. The difference is the optic nerve never changes once it's damaged. So you have this carbon dating capacity of the GCC that I don't think many of us recognize. I've been very fortunate to be involved in 2 major MS trials with over 100 patients. I've also done several idiopathic intracranial hypertension trials where we've had hundreds of patients with elevated nerves. So, the OCT has been a part and parcel of that. In those trials, originally, we weren't using GCC, we were using RNFL, and we didn't see a lot of change. And then one day I happened to image both, and I saw that a patient had an abnormal left eye GCC, but the right eye was normal and the RNFL and the field were normal. We went back to the history and found out that about 10 years earlier, they'd had a 3-day episode of vision change that had been undiagnosed at the time, but ended up leaving me a permanent marker of their previous first MS attack. And since then, I've used it as a major component in my analysis of patients in the neurodegenerative space. So the GCC is a wonderful tool. But this is a classic AD patient. You can see that eaten out process. The optic nerve looks suspicious, but that doesn't reflect anything about the GCC here. That donut shape is pretty classic. This is a great article by David Wong. For those of you who are not familiar with Dr. Wong, I look at him as one of the scions, the highest sort of apex of research in glaucoma and imaging. And to give you a little backstory, he, Carmine Pugliafito, and Joel Schumann, and there's one other person whose name I don't recall, invented the OCT. So he's been with us for a long time. They were all at MIT together. He was an MD, PhD researcher at the time. And his literature is so beautifully poised to our needs as clinicians. It's not this ethereal sort of abstract analysis. It's a true view of what we need to know. And what he did in this study looking at GCC was fascinating. He looked at a total of 188 patients with 277 eyes, of which over a 5-year period, on average, 83% ended up progressing to glaucoma with visual fields, right? So he looked at the baseline NFL GCC parameters, but he didn't look at the disc. He didn't care about the cup to disc ratio. He then looked at visual field evaluations, did a univariate Cox regression analysis, which is a very competent analysis. And here's what he found. If you take this image here and you, let me move myself off. If you look at this, this is fascinating. So his SDOCT, so spectral domain OCT, was superior in identifying progression in glaucoma suspects, preparametric glaucoma, mild glaucoma, and early and moderate disease progression compared to standard automated perimetry. Why did that happen? Well, I mean, look at the bottom bullet. Bottom bullet very clearly says OCT only varies 3% per test. So that's about 6 to 8 microns in that range. Whereas visual fields vary 20% per test. And later in the disease, they vary even more. So it's very difficult to use a visual field and say, oh, that's a loss. Whereas with the OCT, you can repeat it 3 times in 2 weeks and identify the fact that the patient has a definite variation from 6 months ago. So the OCT is easily capable of identifying statistically significant progression in 2 years or less, whereas the SDOCT can take up to 6 years. So you can see why the SDOCT the visual field can take up to 6 years. You can see why the visual field is a crucial part of the diagnosis, and it's not something you want to throw away. But the cold reality is, if you use GCC and you use RNFL, you are going to be much more sensitive in that early patient assessment and identification with that device than you are by doing serial visual fields in the same time period. I still do a visual field at the beginning. We do a visual field when we think there's progression or when we feel that the patient's control is lost. But I don't do visual fields every 3 to 4 months in the early phases. I'll do them once a year because I have an SDOCT, which is much more accurate. The final piece of this study, which I think is absolutely critical for all of us to know, is that RNFL has a floor. And by that, it implies that you can't go below the number of 50 to 60. No matter how damaged the eye is, the RNFL will always read at some sort of baseline number. Here's the dial, right? So the dial never can go past here. It just hits a governor. There's no progression. Even if the visual field's getting worse, this will stay the same. And why does it happen? Because the eye in late phase glaucoma, moderate to advanced disease level, starts to replace RNFL fibers that are lost with astroglial cells. Those astroglial cells are effectively the same thickness And so what's happening is the eye could be getting worse, but it's being replaced by an equally thick fiber that has no functional vision, and therefore the device is reading and it's flat. The industry, i.e. the insurance industry, has known about this for quite some time, and that's why technically you cannot get reimbursed for a patient who you determine has advanced glaucoma, because they know the device on the RNFL side doesn't work. He, in a brilliant reset of the analysis process, found that the GCC can be used much later in the disease. And I've used it in moderate to advanced disease and clearly shown progression when the RNFL has been absolutely flat for the last 2 or 3 years. So when you move into that moderate to advanced stage, then you flip back to visual fields. You should be doing them 3 times, maybe 4 times a year, and using the GCC at the same time to demonstrate a combined analysis, which you did not have the sensitivity to present with just RNFL. This is another phenomenal study by my perspective. This is life-changing for all of us. This is the light study. Look, we've had previous studies. We had the ALT study, we had an SLT study, but they were all very small, relatively speaking, and they were not as well developed in the sense they weren't as multi-centered. They weren't as highly evolved on the recruitment side. Some of them had really bizarre treatment patterns. They were using beta optic and acetazolamide orally versus laser. Nothing that you or I would do in our practice. This study represents the best real-time, real-life perspective on glaucoma that I've witnessed in my career, and it has fundamentally changed my perspective on what I talk to my patients about on first visit. This is something I now offer every patient as first-line therapy. We can either do medicine or we can do laser, Mr. Smith, and both of them work equally well. We have a wonderful study that shows that. It's just really a matter of which one you're more comfortable with. I'm happy to start you in either. 2 years ago, that was never a discussion. It was, let me get you started on the drops. And sometimes we might need a laser down the road. I've completely changed my perspective because this study clearly evidences some important points about both of them that I think we should spend a couple of minutes on. So just to give you a sense of the study, they basically reviewed 16,000, almost 400 patients for possible eligibility and eventually selected 718. They allocated them to two almost perfectly balanced groups. In those groups, they then derived exactly how many spots were going to be delivered, what the energy levels were going to be, and what the retreatment potential of retreatment patterns would be long before the study started. They also looked at complications, precluded repetition, et cetera. Not surprising. The only time oral agents were allowed was as a rescue drug. Otherwise, they used exactly the same typical pattern of treatment that I would use in my office, and you probably do too. Prostaglandins first, beta blockers second, and third line was either CAIs or alpha agonists, okay? Fixed combination drops were allowed, so they even allowed them to do things like Combigan or Kosov, which made life, or Zimbrinza, which made life a lot easier for the patient. So this was a real life study because that's exactly what we do in our office. They then teed that up head to head against SLT. And the part of this that I thought was really interesting was they derived the goal endpoint or the goal of the patient collectively for each person. So in most studies that we've had, all studies we've had in the past that I know of, we pick a number. We say, OAT study, 20%, you either succeed or you fail. The MJIT study, 25%. The normal tension study, 30%. The SIGIT study, 30%. So we had these preset goals. You either won or lost against the goal. Here, they tailored each and every approach based on the group assessment of the patient and said you either met or you did not meet the endpoint goal. Here's the money slide for this one. Look at the third bullet. 36 months, just south of 75% of the patients were at complete control of their IOP without drops. More importantly, if you look at the number of visits between the SLT group and the eye drop group that met goal pressure, there was this not statistically significant, but slightly improved outcome to the SLT group. And then the part that was most compelling is, to me, 11 of the patients in the drop group ended up having to go to surgery. They failed out of the drop group, whereas nobody in the SLT group failed out to surgery in that 3-year period. The bigger picture, though, was this was a quality of life study in addition to a successful IOP control study. And what they found was that it was highly probable that the SLT group cost less if patients had fewer side effects. I mean, that's obviously a ridiculously simple conclusion to derive, because you could have figured that out long before you even saw the study endpoint, that if a patient has a laser, it's much less likely they'll have ocular surface issues. They don't have dry eye. We don't have the reactive BAK issues. Additionally, cost, one time, 3 years, maybe 4, maybe 5. When you get a 5-year patient, I had a patient a couple of weeks ago who's been 10 years out on SLT and still doing really well from her previous use of medication, which she got tired of using and didn't want to try anymore. So this study has materially affected all of us. And I think we need to honestly assess where our patients are. If I have patients with arthritis, patients who have access to insurance issues, this becomes a much more viable first option. Even if you don't believe it's an equal option, we need to start inserting this, because this is to the benefit of our patients. By the way, it can be repeated. So this is the effect of the repeat laser study, which is a subset group of the SLT study or the light study. And here's what they found. I'm going to jump forward here. Oops, here we go. So the fourth bullet was really the big issue. So at any point along the way, if the patient did not meet their goal, they were permitted to have a repeat SLT. And you can see 115 eyes and 90 patients received repeat SLT during the first 18 months. Pre-treatment IOP, initial SLT was significantly higher than before retreatment IOP in 95% of the patients. So what that means is, and this is a complete departure from where we were, 2-3 years ago before this study was released, if I had a patient who failed an SLT, I automatically said, look, we are going to wait a year, or we've just failed, we're not going to go back there. This study turned that 180 degrees and said, I don't care when you fail, 2 months, 3 months, 6 months, 9 months, 12 months, just redo the laser. And you can see 95% of the patients had a lower pressure after the second laser than they did after the first laser. This is a really fascinating concept, because it allows us to have a repeatable therapy that is not medical, that is unique for our patients. Look, I have hundreds of patients who have an SLT that I manage. This hasn't changed my management. I don't make the drugs. I don't make money off the drugs. I don't sell the drugs. I treat my patient. This is just another treatment portal. So for me, it's still looking at OCT, still looking at fields, still checking pressure, still doing tonography, still doing ERGs if I need to, whatever is necessary, right? Those are the important characteristics. And when I think the patient's failing at a next level after SLT, then I'll consult with my surgical partner and we'll go back to the drawing board and come up with a new plan. But the beauty of this is that you have yet another weapon in your belt that you now have complete and total reliability on, and are totally committed to the success of this procedure, just our medication, which, by the way, I didn't mention. In the study, medication worked just as well as SLT. Do not misunderstand that. They were equal. This is the first study that showed that SLT was equal. So this is a David Wong study. This is a glaucoma perfusion study, but just shows you the depth of his work. This is 47 patients, and he was using the OptiView and the neurofibrillary plexus angiogram. So this is an OCTA study. Here's another study that he did. Low perfusion map uses LPA and FPL parameters. So lots of useful things. This is OCTA, and it's a fascinating technology, colleagues. I don't think this is ready for prime time in glaucoma. In retina, no question, this is maybe one of the biggest advances of the last decade in retina, along with anti-VEGF. You in your practice have the ability to look at the vascular, the integrity of the vascular system in your patients at a level that only a retina person could have done with an injection 10 years earlier. Is this as good as a standard angiogram? No, it's not as good. Let's be honest. Is it close? It's pretty close. The new algorithms for analysis are much, much better than they were 2 years ago, greatly better than 4 years ago. And I anticipate they're going to continue to improve as they feed the AI system that's creating new algorithms for the future. Will it ever replace angiography? I don't know. My sense is it probably will at some point when we get exquisitely good at it, but right now it hasn't. But that's in retina. In glaucoma, the issue for me in glaucoma is I have a question, right? So this is OCT moderate glaucoma. You see at 7 o'clock, you see that beautiful, this is courtesy of Robert Weinreb and Linda Zangwell at UC San Diego at the Hamilton Center, right? One of the greatest research centers in the country in glaucoma. kudos to them for their remarkable work. This is a clear decrease in the underlying vascular plexus at the 7 o'clock position. Okay, but go over and look at the nerve over in the RNFL thickness band. There's a wedge there, and the wedge is accompanied by a localized focal erosion, right? So the patient has a notch. I can see that pretty well over there. I don't think I need to see the OCTA. The real answer to OCTA and its success is going to be the following. Does the OCTA in the image you see here precede the development of the image you see on the right by a substantial period, a period of time substantial enough for us to have done something in the middle? Is this the chicken or is it the egg? And I have yet undecided that. I don't think anybody has. On the macular side, it's the chicken. This is the real deal. There's a lot of literature out there looking at small case studies going, oh, hey, I found these 10 patients. I think we found this. That's fantastic. We need a large multi-location clinical trial, which is double-blinded, placebo-controlled. It needs to be independently evaluated. It needs to be published in the peer-reviewed literature. And I'm not talking 20 or 30 patients. We're talking thousands of patients because glaucoma is such a slowly progressive disease. So while I love OCTA for my diabetics, everybody gets one. I love it for my MAC patients. Everybody gets one, regardless of why they're there for the visit. This is yet to be decided in my books. So let's talk about some new technologies. Just finished doing a couple of these today. This is the Melbourne Rapid Field. This is a device that is currently being marketed by M&S Technologies here in the US. As a matter of fact, I just got texted by the gentleman who's their national sales director while I was lecturing. We're getting together next week. He's coming up for dinner in Connecticut to talk about some of the new technologies, and we're going to put them into the practice. So this is a group of super investigators out of Australia. This is, in my mind, the best optometric research team south of the equator in the world. And they're at the University of Melbourne. These are superstars. Dr. Kong, Dr. Vingras recently stepped down as chair in that area. He's been a lifelong friend. This is the device. It's a tablet, which is the one I have. You can use it very flexibly. I used it throughout COVID. I did over 300 visual fields during COVID when everybody else had shut down because of sterilization issues. We were able to sterilize this with a chem wipe, and the patient started off on the next one. Conversely, there's a link that you can send to patients, and I was doing that during COVID, where I would send it to their computer. They would do the visual field at home based on the program, and then subsequently send the field back to me, and I would analyze it without them having to come in. This is magic. This completely disrupts the idea of having a $40,000 device that's stuck in a room that you have no other function for, which is a tremendously high cost per year. And this is FDA approved for both 10-2, 24, 30-2, and progression analysis, and a screening field with progression analysis. So I believe that visual fields are becoming unbundled as regards standard large bulb perimetry, and we're starting to see a massive shift into, and this was driven in large part by telemedicine, but it's also driven by convenience to the patient. I mean, imagine you can put a patient in your office. If you're busy, if you're not in the office, stick them in your office. They could do the visual field there. They could do it out in the waiting room, a little crowded if there's nobody there. They could do it anywhere they want. You can put them anywhere. We have. So I love this device. It works really simply by using a system where, I don't know if I can make this run. Let's see. There we go. So this is just running a field. So this is standard. And all happens is the fixation moves to the lower left, to the lower right, to the upper right, and then to the upper left. Those fields are then mapped in the left, right, down, and up position relative to the central field. And as a result of that, you end up in a situation where they meritage or they merge together, they collage them. And that field looks just like a Humphrey field. You can see it here. You know, the mean deviation here is identical, almost identical. Here's the mean deviation in a field that's a little more advanced. Here's the mean deviation in a mild and mild, kind of early moderate, it's kind of mid-stage moderate, 9 mean deviation on the visual field. And here's one with more advanced disease. So as you can see, this device, and I'm going to show you the data, this is from the McQuarrie study in Sydney, Australia. They looked at 43 patients, or 60 glaucoma is 43 manifest HFA defects, 17 controls. And you can see here, there was no statistical difference in the Kaplan-Meier analysis of these patients between the two devices. And that's what I've seen in the office. All the patients we did had previous fields. We were able to compare them, and I saw no notable difference other than the usual 20% variation, which we talked about earlier. So this is one device that has come forward. This is relatively inexpensive. It's below 8,000 for this device, and it's a really nice little tablet system. I'm going to bump past this one. This is Vivid Vision. I want to talk about this. I've now done 112 patients and about 220 eyes, whatever the number is, right? Not quite. I didn't double over. Some of the patients only had one eye. So this does all the common protocols, right, that are available in the Humphrey. Testing time is about 3 minutes, standard, 1.5 minutes for screening. But then additionally, it does visual acuity, it does color vision, and it does pediatric fields, which are certified under the FDA for approved use and subsequent billing. I have no confidence whatsoever in my HFA system or HVF system. It's just ridiculous. So All Eyes is a virtual reality system, which is beautifully done. Let me show you. So over on the right, this is the standard system that was done on the original study. So Jonathan Myers is out of Wills, one of the top glaucoma people on the East Coast. Katz is additionally a great glaucoma person. Alberto Gonzalez Garcia is a neuro-op out of Baskin Palmer. And I don't know Dr. Razek Jinjad. Razek Hinajad. I don't know that person, but I do know Dr. Garcia well, and I do Dr. Myers very well. Clearly they thought there was excellent correlation between the visual and the standard automated perimetry in normal and glaucoma patients. I would argue the same thing. We've done this, as I said, over 100 times in the last 3 months, maybe even more, probably less than probably 10 weeks. I love this device, and I love it because the patients love it. Put them in a room. The beauty of this, think about it for 2 seconds, colleagues. You put this on. Now, if I turn my head left, the device is still straight in front of me. The visual field is straight in front of me. If I turn my head right, if I go up, if I go down, if I lay on my back, if I look at the ceiling, the device and the field are always straight ahead. In the bowl, you only had one straight ahead. Any deviation from that caused considerable variation in outcome. We've eliminated not all, but a huge percentage of the overall variation levels that we've typically seen with visual fields with this device. So it does pediatric, perimetry, adults. I love the pediatric for kids. The visual field for kids is actually fun. It's a game. It's like a virtual reality game. There's asteroids in it. If the kid sees the asteroid, they have to grab it and bring it to the middle, which implies they saw it, but they're monitoring them for fixation straight ahead. So if they grab that asteroid while looking straight ahead, that's a positive test element. If they haven't, they mark it negatively. You can interpret it. It's patch-free. It tests both eyes simultaneously, but only one eye at a time. So both eyes are open, but just like when you go to the DMV and you do the bilateral test, only one eye is being stimulated. The other eye thinks it's being stimulated, but it's not. Love the system. The other thing there's a little kid doing it. It's so cute. I mean, I had a 4-year-old we did it on about 2 weeks ago. He did fantastic. He came in with a TBI and was complaining of, sort of headaches and visual issues, and had a little bit of convergence insufficiency and sort of typical findings and some saccades and pursuit problems. But he was able to do a visual field and it was normal, which was very gratifying. We were able to get it. He's now under TBI protocol at a local facility that we sent him to because I do think that he suffered some problems, but I could have never gotten a visual field on him any other way that would have been of any value. This is a visual acuity modality. So what you do is you program the patient to do a series. So you can say, look, do a visual acuity first, and then I want you to do color vision, and then I'd like you to do visual field, and the machine will just run. You don't have to go back in the room and even bother to reprogram it. Here's the color vision chart. Really simple test, very simple to do. Love the ability to define this without me or my staff being in the room. And this is Annie. She's a visual virtual assistant, I should say. What we do in the office, just to give you a sense of how we set this up, I have a suite of rooms. In one of the rooms, I have a desktop, and we connected the device to that. I don't have to run it anywhere near that. it runs anywhere because it's Bluetooth. So I'll stick the patient in a far room, which we have no use for, maybe an administrative room, right at a desk. And I'll have them sit there and do the visual fields, and we watch the outcome taking place on the screen in our room so that there's an active monitor. So I can be 100 feet away from the patient and watch them the whole time, and I can listen to her talk to the patient simultaneously. And it's very encouraging. She'll say, hey, you're doing great, look straight ahead, or you know what, you're starting to look a little bit to the left or the right, try to find the target again. Let me help you do that. Remarkably interactive. I've had only one person out of the 100 say she thought it was too interactive. Everybody else thought it was actually very nice to get some encouragement. And I don't have to have a technician sitting in the room the whole time. They're doing something else with me. And quite frankly, I'm generating more revenue when they're working with me doing something else than when they're sitting in that room. So not only do you get reimbursed for the test, the whole context of how the test runs is different. So I think we have a major breakthrough in visual field technology. This is another really important piece of technology that I think we all need to attend to, right? So corneal hysteresis has been around for a while. We've had probably about 9, almost 10 years of this. I've been working with it from the beginning. We've done several studies showing progression within the glaucoma space, which was the original indication for the test. And everybody understands where that was. This is without a doubt the best tool we've ever derived to know who within the glaucomatous population is going to demonstrate progression, right? So this is your rapid progressor identifier, I guess would be the best way to phrase it. That's been there for a while. We've all used it. If you have one, you've used it for that. If you haven't, you should. But recently, Felipe Medeiros came out with a new paper, and this is remarkably devastating, to be honest. I mean, when you look at this is pretty powerful. So what he did was he took the patients that he had in the study group and he broke them into two divisions, right? So he had the above 10.2 millimeters of mercury and below. This is not an IOP measurement. Turns out that the CH is actually measured in millimeters of mercury. That was the original designation. So if you look at this graph and you go back in history a little bit, you might recognize this graph looks very much like a previous graph for corneal thickness in the Oates study. The difference is it's been shown in several studies that corneal hysteresis is much more sensitive than corneal thickness in predicting the future for both glaucoma and now glaucoma suspects. I've always used this test. It was used previously it was paid for, the code. It lost the code because there were so many uses. So the government just said, look, you know what, just keep using it. We're just not going to pay you. They do that periodically when they're out of money. But in this case, we still use it all the time. And the reason is pretty simple. The data we generate from this is so powerful. This will push me over the edge along with another device we'll talk about here in a minute. Even when everything else is on balance, not quite decided whether it's glaucoma or not, if I have this and they're above 10.2, I'm going to watch them. If they're 8.8, I'm going to treat them because I know what this curve looks like. This is like having a patient who has a pachymetry of 525 and a pressure of 24 versus a pachymetry of 590 and a pressure of 24. So if you sort of take that analogy and amp it up, this is corneal thickness on steroids. So great new technology, great new application of a previously well-developed and highly evolved technology. So if you don't have one of these, this is something that I would strongly recommend. It cuts down tremendously on the amount of time you spend getting IOPs. By the way, the IOP in this, the most accurate IOP you can derive. Goldman, CATS, nothing gets close to this. And the other piece with this, which is really powerful, is we have a huge refractive practice. We've done 125,000, 130, 140. I've lost track after a while, but we're well over 125,000 refractive surgical cases in the last 20 years. We have a huge practice, multi-site, multiple surgeons. So we've done a lot. And this device is capable of doing post-refractive IOP accurately, as opposed to Goldman, which Frank Price showed in a brilliant article probably 15 years ago. Goldman's almost useless post-refractive surgery or post-refractive cornea surgery. So transplants, DSECs, DMECs, DALCs, LASIK, RK, PRK, anything you do to alter the corneal structure, Goldman loses efficacy in its analysis. if it was ever good to begin with. This device is the same as a pneumotonometer for the most part. So I use this all the time to get myself a true IOP. I'll give you a little pearl. This is courtesy of my partner, Dr. Robert Noacker, who I consider to be one of the really brilliant minds in the world of glaucoma. And if you have somebody you're working with, you can ask him. Everybody knows Robert. He is a world-renowned, US-renowned glaucoma surgeon, right? He and I lectured together at SECO about 3 years ago, a couple years before COVID. And one of his comments during the middle of the presentation was, one of the most dangerous patients you have in your practice is a -6 who's had refractive surgery and is now plano, has a pressure of 15. Because most of us still, to this day, even though we know that you have to look at the optic nerve, and we know that the optic nerve is the goal and the analysis point that's most important, we tend to look at the pressure. And if you're measuring a patient's pressure with a Goldmann after refractive surgery, you're rolling the dice. You have no idea what's going to happen. Could be okay, could be totally wrong. This device is consistently correct. So this is the faulk faulk medical multifunction device. New technology, picked it up just before COVID started, had a downturn when we were originally there, and now it's on fire. I used it probably 25 times today, maybe more, in my glaucoma base, looking at different aspects of the disease state. So here's a pointer. So if you look here, this device basically replaces your Goldmann tonometer or whatever you're using on the slit lamp. The activating system to the left, the little keypad, dictates which test you're going to run. You have 3 test options. You can do intraocular pressure, which is an intraocular pressure, but it's also a serial tonometry. So this takes, in this case, it took 70 and 64 readings in 10 seconds, measuring over 3 cardiac cycles. That multiple serial IOP measurement, the end value is an averaging of the outcomes, right? Systolic and diastolic IOP are measured. The average IOP is displayed. The IOP variation in the cardiac cycle, or the OPA, is measured. And so what it shows you is within the cardiac cycle, this is 3.2. That's a pretty decent number. I get patients up in the 6s, 7s, and 8s routinely, which tells me they have a huge diurnal cycle and makes them much more vulnerable to progression, as we know from Sanjay Osrani's classic work in about 2000 or so. Second, ophthalmodynamometry. Ophthalmodynamometry is a lost art. This was a technique that used to have a brutal, and when I say brutal, I do mean brutal hand system that had a plunger that had a dial up top with a arrow, with a needle on it, and you would push it into the eye while you, after you dilate the pupil, you push it on the eye until you actually looked in and saw the optic nerve stop beating and the retina went white. As soon as that happened, you stopped and you went, let it go, and it returned, and I would tell you what that was, and then you would watch for the diastolic on the way back, right? I used to do this regularly at the VA when I ran the VA eye service in Ohio after I finished my residency, because that's all we had. And we did it for the same reason we do it today. Patients with amaurosis fugax, patients with normal tension disease, patients with retinal vascular disease that's asymmetric, all have the potential to be identified as significant underlying systemic vascular disease patients by simply measuring the information that you can get from the mean central arterial pressure, right, or the MCRAP. So the data captured during this is during 3 cardiac cycles, just as the T-serial is. And the true ocular perfusion pressure, which is the OPP, is derived. So the MCRAP, which is really the central retinal artery pressure, is an indirect analog or a derivative representative of the carotid, well, cardiac and carotid pressure on each side, right? So the goal here is to identify patients, like a woman about 3.5, 4 months ago came in. A week earlier, she'd had an episode of vision loss in one eye. I did a stethoscope exam of the carotid. I did not hear a bruit, but you know that if it's less than 30% or more than 80%, there's no bruit. It could have been normal. I couldn't tell. I ran this test. Right side was about 59.8. The left side was 46.4. That was the side she had the amaurosis on, right? That told me that she had a normal structural problem between the heart and the ophthalmic artery, which means between the aortic valve and the aortic valve and the and the ophthalmic artery, the central retinal artery. Sent her out. Literally the next day, she had a full-on cardiovascular workup at a local facility I sent her to. Gentleman called me and he said, you know, this is impressive. He said, she told me you had a tool in your office that told her this was abnormal. What is that? I explained it to him. He said, are you taking new patients? I said, absolutely. He said, I will use you regularly. I probably had a half a dozen patients from him since then, where he didn't really have a good answer and he wanted to get a little more info before he went invasive. And we found 2 of those patients have significant abnormalities. So this device is just amazing in a smaller subset. The other group of people this works really well on, colleagues, is those who have normal tension glaucoma, to differentiate whether it's a perfusion issue into the nerve or whether it's another problem. In almost all cases, these patients have really low ophthalmic artery pressures, which tells you that the optic nerve pressure, the intraocular pressure they have that opposes that, is actually relatively greater than it would be in a normal eye. And that's why they're suffering vision loss at pressures of 12 and 15. And then the final one is tonography. So tonography is a really important component to the analysis, right? So tonography is the essence of the disease. If you think about what glaucoma is as a fundamental pathophysiology, it's the inability to create fluid and exit it at the same rate. So if you look at Bernoullian flow mechanics, right? So he was the person who described the original flow mechanics of most tubes, and engineers use it all the time to understand water flow and liquid flow throughout tubes and systems. Well, that's what we are. The eye is a closed system. So if you make X, but you exit half X, that means X is going to build up and create more pressure until it gets to the same place where this at twice the pressure can now exit this at an equal rate. That's glaucoma. When these two are equal at a normal level, I make as much as I exit, pressures between 12 and 17 or 20, right? When it's 30, it means that the trabeculum is damaged and the outflow is restricted. So the continuous creation of flow can only be offset by increasing the pressure and pushing it out faster. And that's what this measures. Back in the day, again, back in my VA days, we used to do tonography. It was about a 45-minute test. It had a Shiatz tonometer and a graphing system. You simply place that on there. It would measure the relative outflow of the eye over time, and you'd watch it decay with various weights, and you had these really complex formulas that you had to work out. And it was a research instrument for the most part. Today, if you wanted, 5 years ago, if you wanted to get it done, you'd send it to the Hamilton Eye Center because they had a facility to do that. Today, you can do this in your office in 10 seconds. It's digital, it's phenomenal. I use this on every patient who I suspicion has glaucoma. This is my new best test. Love this device. You can just go to them online, the Faulk Medical Multi-System. And it's reasonably well priced, things about $13,000 or $14,000. But the beauty of this is, unlike all the other tests we've talked about in visual fields, which get reimbursed, this, you can get reimbursed for all 3 of these. On average, when I take tonography, which is not covered by Medicare, but is covered by most of the commercials, I take ophthalmodynamometry, which is reimbursed at a relatively lower rate of about $25, and serial tonometry, which is around $70. I'm averaging about $55 to $60 per test, and I'm using this sometimes 20 times a day. So if you look at those numbers and you're building a practice, this is a tool that helps you create incredibly important information about. If I see a patient who has a point, by the way, 0.18 is the break point for normal tonography outflow. It's kind of like 10.2 on the corneal hysteresis. So today I had a patient at a 0.13, repeated it another time as 0.14. The other eye was about 0.19. That eye had a very suspicious looking visual field, but it was not confirmatory. The RNFL and the GCC were again suspicious. The pressure was 19. The other eye was 14. CH was 9.6 or 9.6 in this eye and about 10.4 in the other eye. What did it do? I decided to go ahead and treat the patient based on this. And why? Because I know that a tonography that low will eventually only produce damage to the nerve. All the other factors that I've presented are relative. This is absolute. Best analogy I can give you, this is the A1C hemoglobin of glaucoma. IOP is the fasting blood sugar. And you can make that comparison very easily. Fasting blood sugars can be all over the place on a given moment at a given day. They're valuable, but they're not indicative. This is indicative disease, just like A1C is indicative of patient's control. So great tool. It's just a quick case. I think we may or may not have enough time for these, but let me give you one quick case. This patient, 63-year-old white male, presented for consultation. VA was 2020. Peak IOPs at the referring practice were 26 and 23. Got him at 21 and 19. Tonography was 8.18 and 0.24. PACs were even at 560. CH is down in both eyes. So you have two really interesting factors: the asymmetry of the CH and the relative previous IOP at 26 and 23. Here's the OCTs. You can see significant damage to the right, but look at that right eye. That's a megapupil. It's a huge eye. It's not 2.2, it's not 2.5, it's 3.0. Left eye is totally normal, has a cup to disc about 0.56. So everything about this is skewed to the right eye's abnormality. So here's that beautiful wiper defect that we talked about before. The left eye actually had a decreased area as well inferiorly, which I did not pick up on with the RNFL. But when you go back and look at the nerve, you can see that there's a notable diminution of that superior bundle there. So here's the visual field loss. This is real. This is a nasal step in that right eye that's consistent with the patient's presentation. This actually had a lot of abnormalities and was considered extremely high false positive. So when you wipe that out, this was actually a normal field. But look here, the pressure went from 21 and 19 down to 17 and 15. So it went down 4. Not bad. Put them on Vyzulta. But tonography was 0.25 and 0.29. So the tonography skyrocketed both eyes. So what this tells you is, had I not known the tonography here and known how robustly it responded to the Vyzulta, I might have looked at this and said, I don't think the Vyzulta is doing all that well. What really happens is I didn't know what the real pressure was at the peak. So what I'm looking at here is this is probably, this obviously is a very good result. It just isn't good against that one moment of pressure I had. This tonography is a bigger read over a long period of time, showing you the drug's working exceptionally well. I use this on all of my new starts. I see them back. When I see them back, we remeasure it, and we look for a significant change in outflow. If the outflow changes, I have a successful therapeutic intervention. Same thing with all of our surgical interventions as well. Cut through this. Oh, by the way, great slide. Just had to put this in. This is a patient who's 1 day out after a Zen, and the pressure is 2, maybe 3. So he has got ocular hypotony. Those are the best, that's the best picture of choroidals I've ever seen in my life. He's got 5 beautiful big choroidals, 6 big choroidals sticking out there. And then in this, that's him about a week and a half later when his pressure was 14. So did well. All right, so let's talk, you know what, I'm going to skip this. Anyway, let's talk about this. This is kind of cool. So this is the Equinox, and I'm sad to tell you, we actually were slated to be one of the clinical trial centers, and it was during COVID, and we just could not bring together the team necessary to do this. This is one of the fascinating new devices. It's the first ever non-medical, non-surgical IOP control system. It uses a reverse vacuum goggle system that lowers pressure at night. The patient sleeps through the night with the goggles on, and the pressure is lowered as a result of that process, right? So this is brilliantly devised. John Berdahl is one of the great young minds in ophthalmology. I think one of the great people of his generation. He's done a number of things, among which is a glaucoma trained person, but he's also a refractive surgery person. He's a Renaissance individual by my perspective, and he practices in Sioux Falls, South Dakota, with 2 of the best ODs I know in America, Mitch Eibach and Justin Schweitzer. If you know them, congratulations. If you don't, you should. They're going to lead us all to the future. So you know, what a powerhouse group they have out in Sioux Falls, South Dakota. Who would have thought, right? That said, the device basically uses the principles learned in deep space travel, in which astronauts were developing papilledema as a result of cortical pressure never changing, but the outside gravity dropping. So this is no gravity out here. In here is full-on normal pressure. So cerebrospinal fluid pressure doesn't change. So the optic nerve started to protrude. So they developed a treatment, which was a positive pressure device, which they wore on a cyclical basis to decrease the papillary edema or keep it under control, which they were successful at. This device was then developed as a result of that. Looking at how they did it, he reversed the system and took the pressure away. I'm going to take you to the last slide here. So here's what happens. Absolute IOP after the application of the vacuum to local atmospheric environment. You can see he was able to drop the pressure by about 10 millimeters of mercury. So really remarkable. It's an incredible process to observe. I'm so sad we couldn't do this. We needed to have a sleep lab be able to provide 3 sleep assessments with the patient having the device on. I couldn't get a single pulmonologist to do this for us. So sadly, didn't get it. This is a cool device. If you're looking for an upgrade that's inexpensive, this will make your glaucoma better. It's that simple. Does it make it perfect? No. This is not, in my mind, this is not as good as the Aura by any means, but it beats the heck out of the Goldman. And it's an inexpensive $200 and some dollar, $250, $275. This is a Reichert product out of Buffalo, as is the Aura. And this device is called the CATS. This is Sean McCaffrey. He's out of, I think it's Phoenix, Arizona. It might be a different time. He's in Arizona. And his system is interesting because this is standard Goldman. This is how Goldman applanates the eye. This is his system and how he has a contour applanation, which has a different relationship with the tear film. And I'm going to cut to the chase on this because there's a lot of data, but let me just get to the slide that matters. This one on the right is the most important, the red and the blue. So with a GAT, okay, the measurement error from true intracameral pressure or a pneumotonometer is about 5. With his device, it's about 2.5. So what I would tell you to take from this is there are no devices that measure in this fashion that are absolute. But if you want a device that makes you a much better clinician and narrows down your error range from this to this, so you have less error on every visit, which eventually evolves into a much more accurate assessment of the patient, this is the way to go, colleagues. This is an amazing tool. $275. I've changed all of mine over. The one room that has the faulk, and then everything else has a CATS on. So it's good. I'm not going to spend much time with this because I know the next speaker is going to spend some time, but I do want to show you these. I have to show you, this is some of the coolest slides out there. This is Ropressa, and a patient who had an elevated IOP after there was a corneal transplant patient. Came in looking like this. Obviously, anytime you have a patient with a unique finding, it's always critical to do one thing first and then work after that. First thing is take the picture and then figure out what's going on. So we took the picture, and here it is in a different view. This is almost artwork-like. And then here it is about an hour later when the pressure's gone. So why this happens, I don't think anybody knows. I've seen it twice now, but it can happen with nitardecim. So if you see it, it automatically, you know what this is like? This is like microcystic edema in a post-op patient on day 1. You see that beautiful granular surface, the vision's 2080, 2100, and you measure the pressure and it's 45, okay? The cornea responds really uniquely, and in particular in patients who have had corneal surgery in addition to other issues in their life. In this patient, the patient was glaucoma and they had a transplant, and that was a picture. You'll hopefully never see that again. I'm not going to spend any time on this. I do want to talk just 2 seconds about this. In the world of drops that are a lot of Me Too's, and particularly now because there's so much pressure to get drops to our patients in the form of prior authorizations or sort of fighting for branded drugs, which is, I think, absolutely appropriate in some instances. This is one of the drugs, and the next drug by Zolta is an equally important drug to fight for because they both have almost identical data when it comes to extraordinary IOP responses. I'm going to show you this one because the slide is just so visibly evident. So if you look at the response between the green bar, which is Rocklatan, which is Ropressa, and Zalatan or latanoprost, and you look at the sort of the pumpkin bar, which is latanoprost by itself, statistically significant, yeah, but not that much, to be honest. Then you go down to a 25% or greater response, and now you're starting to get a little separation, but it still is not massive. But look what happens when you go to 30%. Rocklatan is twice as likely to give you 30% or more than latanoprost. It is 2.5 times as likely to give you 35%, and it is 3 times as likely to give you 40% or more. Every millimeter of mercury matters. This matters. Will I fight you for travoprost versus latanoprost? Heck no. Would I fight you for branded Lumigan? Yeah, I probably would if I felt that that couldn't get either of these. But in a day and age when these are available, these are clearly superior to the other drugs. We know this. The clinical trials evidence that. What wasn't done in the clinical trial was this head-to-head with latanoprost. This is old school latanoprost. This isn't generic. So if you take the generics and understand that none of those are as evolved and none of those have a clinical trial to support their efficacy, it's probably even more than this. But at minimum, compared to Xalotane, the old school, this is the difference. The drug just works better. It's that simple. I fight for 2 drugs, this one and Vyzulta. I just did 3 prior auths today. I did a second prior auth on a refusal for Rocklatan because the results were so good. And an 82-year-old woman who's going blind from glaucoma has had 2 surgeries, can't undergo another one because of some physical issues and a personal concern. And she's doing really well with Rocklatan. Her pressure's 11 and 12. I'm happy with that. Can't get the company to pay for it. So today we wrote a letter. Letter basically said, now that you've taken over the care of this patient, I'm passing on the medical and legal responsibilities that you inherit when you decide to treat the patient over and above my recommendations. Please advise, please return the signed document attached with the understanding that this releases me from the medical care of this individual and has been taken over by your corporation. Wrote it to a CEO of one of the companies. It was one of the insurance companies. We'll see what happens. In the past, I've actually got pretty good traction on that. But nonetheless, excellent. Come Vyzulta. This is another drug. We'll talk about it tomorrow. Same thing here. Big differences between this and generic latanoprost. So when you're treating glaucoma, understand there are drugs and there are better drugs. These 2 are better drugs. The other drugs are good. They've worked really well for a long time. And if you can't possibly get these, that's what you're left with. The one factor I will drop back to instead of going forward with this is simply the following. In a world of really complex analysis with drugs, prior authorizations, insurance availability, the one thing that always is covered is SLT, almost always. I've never had a patient not covered with SLT. Aww. So be sure to look at that. Yeah. Somebody's broken through the line there and having a personal conversation. So we're going to talk about the next generation of glaucoma therapy. This is a big deal, colleagues. This is a very big deal. All of us will be affected by this eventually. All of us will end up having some form of utilization for our patients. The number one reason that this is going to succeed, well, there's 3 reasons. First reason, the number one reason for failure in glaucoma is compliance. It's that simple. It never changes. It's always compliance. There's so many studies. Weinrib study out of California, a couple others I can mention that were done that were really large, 20, 30,000 patient studies. They looked and they found that even on a PGA, you're lucky if the patient at 6 months out is taking it every other day on average. Second, medications cause plummeting. Third, medications almost erase compliance. Some of the studies show that at 25% of the regular daily dose is being used. So if you believe your patients are following all your instructions all the time, you're probably delusional. I'm not being insulting, I'm just being honest and observational. If you understand that the vast majority of your patients are not doing what you want, but you're getting the numbers you need, maybe that's because they're taking the medication 2 or 3 days before they come in because they know they're going to see you, sort of the way people floss before they go to the dentist, even though they haven't done it for 6 months. I can tell when you're not getting better, and I can tell when things are not good. There's a lot of ways to ask the question. What I do is say, Mrs. Jones, tell me how many times a day you take the green cap, or the yellow cap, or the orange cap, or the purple cap, or the blue cap, since they're all color-coded, right? I want to know what you know about your medications. The vast majority of patients can't come up with that. And eventually a lot of them say, well, I think I just ran out of that one yesterday, but I still have this one. Anytime you have the, I just ran out of this, that's code for, I haven't taken this in a while. So one of the reasons these devices are so actively being pursued, funded, and FDA enhanced, they're moving this along, is because we're taking the compliance out of the hands of the patient and putting it back in your hands. So where can we use, what devices are available? What systems are available? Let's spend a couple of minutes. So this is Maddie Therapeutics. They're actually based out of, I want to say, I think maybe Arizona at this point. I don't think they're in California anymore. But anyway, this is a device that uses a punctal insert, much like a punctal plug, except in this case, the punctal insert is devised in the following fashion. You have a drug core, which is then covered with a polymer sleeve and then subsequently shielded with the cyanoacrylate film. It's placed into the punctal system. It's a dead-end system. It's a one-way system, so there's no backflow. And the lysozymes from your tears cause you to have the drug slowly dissolve and elute into the tear film over a 3-month period. I will disclose, I have to disclose, that I was and still am a clinical investigator for them. I did the phase 2 trials, so the efficacy, the safety and comfort trials. I will admit, additionally, that putting this is like, it looks like a stiff, almost like a pipe, like that. It's not. It's like a wet ramen noodle. It's a little flexible. Took me the first couple to kind of figure this through. They have a nice video. Went back and looked at the video a second time, watched what he did. Didn't think I needed to do that. So I didn't replicate, but when I did the second time, I replicated it. And after that, it was fine. They all went in easily and they all come out really easily. The goal here is to get 3, maybe 4 months, depending on how the patient responds to the drug. And then you replace this on that serial basis as you would when you have a patient return for their visual fields or their photos or their OCTs or maybe the tonography or whatever testing you're going to do over your usual annual series of tests for your glaucoma patients. The beauty of it is you have consistent delivery over a prolonged period of time. The system's easily identified in the puncture. The patient just pulls it down every day and goes, yep, still there. And I have an appointment with my doctor in this week of September or October. Is this better? If a patient took their drop every day, they would have about a 20% higher rate of response than this. The way your patients are currently taking, based on all the studies, this is better than the way they're doing it. I would take this in a heartbeat if I'm a clinician, because at least I know I'm getting 80% of the desired response or the predicted response, but I'm getting it every day. I'm flattening that diurnal curve into this. I'm not doing big waves. I'm doing just little sinusoidal waves. Long term, that's better for the patient. The other factor is, if you look at the data here, which is really interesting, look at the estimated drop level. So you deliver a drop to the eye, you're probably looking at 15, 25 micrograms per day, active therapeutic dose. With this system, and by the way, their data on the IOP side is much better with travoprost, so that's going to be the drug that's going to be in there. This is 0.5 to 0.7, so it's 30 times less to up to 40 to almost 50 times less drug. And what you see is the eye is whiter, it's quieter, the ocular surface is clearer, the vision's better. This is just a much better system overall. And it's something that we're going to continue to see. So here you go with the travoprost versus the other. Oh, by the way, they have cleared the hurdle for their system, which is the Evolute in a post-operative setting where you can insert the Nepafenac, which is their NSAID. That was how they got approval for the device and then subsequent drug through the FDA. Once that's done and it's through phase 3s, which will be sometime next year, you're going to see them go for release. They'll file for their FDA release. And then once that's done, then you're going to see them go back and start looking at individual drugs. The big ticket item here is going to be glaucoma, because that's a chronic therapy. You're going to be doing that for the rest of your life and the patient's life if this is a model that works well. And so far, it seems to work very well. And I anticipate that this is going to change everything that we do. I consider this one of the major disruptive technologies in glaucoma therapy of the last decade, along with that SLT study I told you about. Ocular Therapeutics is a competing company. They have a product that's called Dextenza, which originally was released under FDA approval for postoperative inflammation in cataract surgery. And the company just received approval last week, maybe Wednesday, Thursday, for the use of the same product for seasonal allergies. So this is an extremely low dose dexamethasone impregnated collagen plug. There's a little bit of cross-linking that takes place to give it the structure. They contend, and I think it's quite accurate, that they can put almost any drug they want into this eventually. They're also going to go for the glaucoma space. As you can see here, they have about an 80% reduction, just as the other product. I'm not sure who gets to the finish line first for glaucoma. They've already made it to the finish line for their product on a regular basis. I have yet to use this because up until now, it could only be used at the time of cataract surgery for reimbursement. Now that it's been approved for seasonal allergy, I'll be interested to see how long it takes for the insurance companies to start to reimburse for this, but it could be a great drug. And we need to start getting used to that concept. So I think it's a perfect segue for us to move into glaucoma, is to have both postoperative or NSAID-based control of the eye, postoperatively or otherwise, and absolutely steroid-based control of the eye. So the use of these non-steroid drop systems, and there's several of them out there, is going to revolutionize how we do business in the glaucoma world. Contact lenses. Yeah. So there's a couple of them. There's one that's called diopter, which I don't think I have the slides for in here. I, again, will acknowledge that I'm a clinical investigator for them. We're actually in the middle of a clinical trial right now. That lens uses a vitamin E matrix within a contact lens that allows you to have a very sustained and predictable, sustained embedding of the drug, and then a predictable release over a week, 10 days, 2 weeks. They have several different products they're looking at. I'm really excited about a couple of them. The glaucoma product, I love the idea, putting a lens on. I just don't know how many of my senior patients are going to be able to put a lens in and exchange it. And I know they're not going to want to come in every week or so to do that. But it's a simple way to deliver a very small dose of the drug and still get the major IOP returns. This is a group out of Dan Cohane and Joe Cialino out of Mass Eye and Ear. And this was an original lens back in the 16s. They got approval up to the level of go forward, but they never really converted it. Diopters moved much further than they did. Diopter is a really interesting product where they're going to impregnate a standard bandage lens type of material and structure, and they're going to impregnate it with an antibiotic that will be there for 7 days. So instead of having to get the antibiotic to put in the eye after the abrasion or the office procedure or the foreign body removal or debridement or filamentary keratitis removal, whatever you're going to do that you would normally use a bandage lens, instead you would use theirs, place it on the eye, and the antibiotic's already in it. So it's just one and out, which I love. Don't have to worry about the patient going to the pharmacy and getting additional input. So this is Durista. Durista is the first approved intraocular injectable IOP controlling drug. This is a AbbVie, Allergan/AbbVie product based out in California, out of their California research facilities. And it involves the placement of this pellet into the anterior segment. So a couple of big view comments about this. This is really exciting, colleagues, to have a drug that works this well, and it does work very well. We've used this countless times already to control IOP with almost no anterior segment awareness. The eyes are white, they're quiet, the corneas are clearer, the ocular surface is better. The IOP is better. IOP here is similar to what we get with Rocklatan and Vyzulta. It's close to 9 millimeters of mercury, it's about 8.5. If you have that same drug on the outside, you're getting about 7.4, maybe 7.5 max. So as a drug, it works exceptionally well. This is the element over 12 months. The study, by the way, this is the inserter. In the study, the insertions were done in an operating room setting, ASC or otherwise. In our office, we do them with a slit lamp and find that to be perfectly fine. We can do them at the OR if the patient's more comfortable, but for the most part, patients don't find that to be a big issue. The drug delivery system used with this has been modified to provide a steady state release. And there's a very complex formula that I'm not going to bother sharing with you on how they are able to predict what that release is going to be. And then this is, yeah, there's the formula right there for the release of polymer. And then this is the multi-center study with 20 months of follow-up. So here you can see easily the drug is superior to the use of the timolol in the study, which, by the way, if you haven't done a lot of FDA studies, timolol is the comparator for all drugs. So that's the gold standard for the FDA. So all drugs have to be either equal to, or they have to be non-inferior to timolol. All right. So in this case, they're clearly non-inferior for the first 3 months, and they're only slightly inferior after that. And so if you talk to, I've talked to several clinical investigators, the principals in this study. Several of them have lectured at the NGS for me over the last several years. And they're talking about patients easily, significant percentage of patients at 6 months out. Now, the FDA allows you to do this once. And the reason for that is they're trying to avoid this. So the contraindications here would be active or suspected disease, not a surprise. Anybody with endothelial disease of any type, Fuchs particularly, but you can have other versions of it, which are significant. Prior corneal transplantation or endothelial transplants, so DSECs, BMECs, PKs, that type of thing. A complex surgery, ruptured capsule, risk of implant migration to posterior segment, et cetera, and then hypersensitivity to bematoprost or any of the kind of component parts. So the FDA put a 6-month hook on this and said, you can't go any further. I believe, by the way, the study to look at the second application of this is already underway. Met with one of the principal investigators last weekend. That study is going quite well, and I anticipate that they will see I think you're going to get a positive out of this. I don't see how that doesn't happen, given all of the need that this has created. Right now, this is being used as a bridge to get a patient out of a complex situation. Think about this. If you're taking a patient to surgery that involves something other than surgery in the angle, so you're not doing an eye inject, or you're not doing a hydrus, but instead you're going to be doing some form of tube, like a Zen or maybe an Ahmed valve, this is the perfect way to transition them in. Because what you can do is effectively eliminate all or most of the topical medications. We know from a number of studies on tube-based procedures or bleb-based procedures, trabs, Ahmeds, Zens, et cetera, express mini shunts, that patients who have been off medication, washed out, as it were, before doing the procedure, are much more likely to succeed long-term than individuals who were unable to be washed out. And the reason for that is the drugs produce inflammation in the conjunctiva. That then translates into post-operative subconjunctival fibrosis, which causes the bleb to collapse or the tube to fail. So we're concerned that the use of this drug long-term could cause corneal issues. Absolutely, you got to watch for that. That needs to be adjudicated. But the flip side is that having this as a precursor drug inside the eye with no topical effect, allowing the eye to clean up. And by the way, I have 80-year-olds whose eyes look white and quiet like the background of the screen. They haven't looked like that in 20 years because they've been on glaucoma meds. So I do think this device is a critical new long-term system, sustained release. I think it gets approval the second time around. I'll be really surprised if it doesn't. And when it does, you're going to see a revolution in glaucoma therapy, because once it gets second, third, and fourth level approval, you can keep using it. I can't tell you, I mean, all of our retina colleagues have created a future for this drug because they're injecting anti-VEGF and steroids into people's eyes at an unbelievable rate. They've effectively diffused the fear of that. So it's not fearful anymore. If you did this twice a year, I would do this in a heartbeat compared to anything else. Is it as good as SLT? Yeah, SLT is as good as this. But if they've already had SLT or they haven't had SLT, this is a great gateway drug. I hate to use that term, but it's a decent application. Start them on this. They have a great response. Do the SLT next. It's perfect. And that's what a lot of doctors are talking about in the glaucoma space. Glaucoma specialists are saying this is a great way to transition from topical therapy to non-topical therapy to surgical therapy. It's sort of a 1, 2, 3 step as opposed to 1, 3 with the SLT. So even though we talked about that being a first-line therapy, this also could be first-line therapy once it's looked at as a long-term repetitive system. This is the Glaukos iDose. This is not approved yet. Very similar concept. This one also has an internal device. Sorry about that. We'll go back to that slide in a minute. So the internal device there is a replacement device. So this one's placed. By the way, the other one, if it doesn't go away, and there's a chance that it won't, it might not completely reabsorb. Well, let me, 2 comments. Let me go back. So let's look at the device itself. Right there. So envision this, colleagues, sort of a big picture of this. 12 months out, the system's, the element's still there. Do you put another one in? Because if the first one didn't dissolve, the second one will. And when does this become too much? When are there too many of these? Nobody's resolved that. Significant portion of patients it completely dissolves. The other issue is we know by the studies, some of these, when these were taken out and looked at, there's a point far before the IOP starts to lose control that these patients end up with no drug in that element, and yet the IOP continues to be well controlled. We've known for a long time that when a patient is taken off of a PGA, let's say, particularly a PGA here, you sometimes have individuals who come back a month, 2, 3 months later, pressure's still great. They're going, wow, did they really need the drug? Well, it turns out that, yeah, they did. And the drug actually did exactly what you wanted. It remodeled the trabeculum and made it more labile to outflow, or more capable. And it did that not just when it was active, it did it and then left a permanent or semi-permanent effect on the trabeculum to continue that process forward. And I think that's a really critical aspect of putting drugs in the eye, is that we are just beginning to understand all of the potential positives that that creates above and beyond just the IOP control for the moment. So I think this drug, and there are several others outside the US that are being looked at, are going to be a mainstay of future therapy for us and in our world. And we need to work with individuals who have access, or we need to move our profession forward and be able to do it ourselves. I'm perfectly fine with either of those options, but I am not good with the idea that we want to sort of step back and protect the space we've worked so hard to get in the glaucoma world, in the glaucoma arena, and only give our patients topical therapy with drops when in fact so many of those other options are available. Let's talk a little bit about MIGS. So I don't know how many of you have had patients who've had MIGS done. This has become a very popular, extremely popular procedure. MIGS is the hottest topic in glaucoma in ophthalmology. And the reason for that is we've only had 3 new medications in the last 20 years topically. We've had the new access systems for long-term or extended therapy, which are very exciting, which we talked about. We have new technologies for diagnosis, which are extremely exciting. And those are developing constantly. But on a surgical side, we had traditionally ALT, then it became SLT. Then we had medication before and after that. And then basically we sort of limped along until the patient needed either a tube or a trab. And it was usually trab first. Tubes were probably a little more rapidly moved into, simply because those patients either have uveitic, neovascular, traumatic, or other complex glaucomas that had no other option other than immediate surgical therapy. Whereas with trabs, you tend to just kick the can down the road until you couldn't wait any longer than you did a trab. Because trab's a huge procedure. Medicine, laser, more medicine, trab over here. In between, you had the space between here and trab that now is filled up with, I think we have 18 different procedures that we do on a regular basis in one way or another, or 18 procedures probably have 7 or 8 common applications, different versions of the same procedure. And now you have 7 or 8 different ones. And then on top of that, this is where the real beauty of MIGS is, almost everybody that I send to my partner for surgery ends up having a mixed procedure at some point. So they may start off with procedure A, they may do an eye injected cataract surgery, and then eventually they may go back and do an omni and a hydrus. So now you have three MIGS procedures over the course of 3 or 4 years, each of those planned to keep the pressure down and basically keep the patient off medication. So let's talk a little bit about this procedure. First and foremost, the distribution of aqueous channels or collector channels or veins is not equal. The difficult part is to determine where the hot spots are. There's a couple ways to do it. You can put tryptan blue in the eye after you've done the cataract surgery, and you can watch what happens to the outflow channels around the limbal margin and into the conjunctiva. Find where there's the densest release of the tryptan blue and put the eye inject there. That's one way to do it. The other is to understand that at minimum, the more elements you put into the eye, the more likely you are to hit a hot collector channel and actually get a really good response versus the standard response. This is the insertion of a micro bypass stent or an eye stent. This is eye stent original. The new eye inject we'll talk about here in just a minute. What we're doing here is you're finding the trabecular meshwork, okay? And then you're going to go ahead and you make a little bit of a down angle push into the meshwork into Schlemm's canal. You'll see the element disappear here in a minute. Okay, and then that is inserted. Then you roll the inserter towards you and you push the release button, very much like putting in a silicone punctal plug. You have to know just how much pressure to exert. And there it is, it's there. So give it a minute, we'll roll the eye. See that little circle there? That's the eye stent. Now, the new eye stents are an eye inject. So the original, and the injector is that center element there. These look very much like a standard silicone punctal plug. They're a much simpler insertion. You go across chamber, you find your best aqueous collector channel. You push into the trabeculum until you feel the pop. You release it. You move over 2 o'clock hours, 2.5, 3 o'clock hours, find the next best channel, place a second element there, withdraw the inserter, you're done. Not hard at all, to be blunt. No disrespect to my colleagues. Look, it's difficult when the angle's narrow. It's difficult, but in a cataract surgery, if you've done cataract surgery, the angle should be open, right? Sometimes it's hard to read the anatomy. I don't disagree with that. If you do a lot of gonioscopy, you'll understand what I just said. I mean, sometimes you look at it, it's like, wow, where's the trabeculum? Where's the scleral spur? Where's Schwalbe's line? Everything looks the same color. Those are tougher. But in most patients, if there's a little bit of pigment in the pigmented trabeculum and in the non-pigmented trabeculum, we have that differentiation. It's very clear where the Schlemm's canal is going to be at. So great device. How does it work? It works really well. This is the inserter for the tube, and this is what it looks like schematically. The big picture here is if you want to lower pressure about one medication, this has a 75% chance of doing that for you. If you just do cataract surgery, you have a 50% chance of doing that. So the combined efforts of cataract surgery with an eye inject system gives you a 50% greater probability that you will not be on, a patient will not be on that one medication. So I look at these devices, especially the angle-based ones, and say, what can I get from this as a clinician? If I refer to my partner and say, look, why don't we do this? And he agrees. What am I expecting? I'm expecting that I should have about a 3 out of 4 chance that this will control the overall IOP 75% of the time with no medication. 25% of the time, you still have to be on some drop, maybe not the same drop. If you have 2 elements, there's a little bit higher chance that you're going to be off meds, maybe 80, 82, 83%, which is great. This is what I would do in a heartbeat. If I was having cataract surgery, this is literally 0 additional risk. And you have a reasonably higher chance, 50 to 60% higher, that you're going to lower IOP. So I like this system. I like this device for a single system. It's easy. It's routine. It's covered pretty well by the insurance companies at the time of surgery. That said, a device which I believe is the real tool in the toolbox for glaucoma, as my patients are, this is more of a 1.5, maybe even a 2 drug reduction. This is a Hydrus by Avantis. It's a Horizon trial. It was a study that was done. That's what they look like. So they occupy 1/4 of the anterior chamber. So you take a pizza and cut it in 4 parts. This is one of the pieces of the pie. It's done by placing the device into Schlemm's canal. In many instances, we'll viscodilate the canal first. That's called an omni. I'll show you the video of that. And it's a really useful tool because for most of us, I don't think we really understood up until recently that the Schlemm's canal is not an open tube for the patient's whole lifetime. It scars frequently, and you have these adhesions or synechia within the canal. And one of the best ways to increase flow is to break those synechia and give yourself a full 360 exit. So what we do is we do a full 360 viscocanalostomy of the, or canaloplasty of the canal. And then subsequently, we take the device and we insert it into that newly opened space. And now you have a long-term, wide open Schlemm's canal that cannot collapse over a quarter of the eye ankle. Oops. This is the schematic of what it looks like. It's actually a really cool system. And here's a video. Great. So there's the inserter. You can see the device being slipped in. So there's a roll, there's like a roll bar there. It just rolls in. And you pick usually the supratemporal, whatever quadrant is easiest, depends on where the surgeon likes to operate. And the beauty of this device is there's that little element, that flange that stays out. So you can see it's in place. It also is parallel with the iris, so you don't have to worry about endothelial disease. And I have a really good view of the element there. This, in conjunction with cataract surgery, is capable of giving you about a 35% reduction in IOP, which is easily a prostaglandin, and probably a prostaglandin and maybe a beta blocker, or maybe an alpha agonist, okay? So very useful tool. And here it is again. There we go. So this gives you 34%. The Compass, which was a CyPass study, which is unfortunately off the market, was 25. And the eye inject gives you about 22% cataract surgery. So you can see if the eye inject is a single med, this is a med and a half to maybe a med and 3/4. And that's what I would tell you is where we routinely find, I routinely find it. This is our most popular procedure. This is the Zen, and I don't think this video is going to work. It's not. Let's just take a look. So this is a 6.2 millimeter tube, I think it is, or 6.1. And it's a gelatin material. And what happens is it's a tube procedure. So it's much like an Ahmed valve, as you can see on the left, except there's far, far less invasion to the corneal tissue. And subsequently, as a result, the ability to control hypotony is one of its greatest features. I find this to be a terrific device when you need 2 or maybe 3 drug reduction control. And I'm going to show you a study here, which is quite remarkable. We use this a lot. So the eye inject, or the eye inject system, which is 2 stents, the Omni with a Hydrus, which is a next level up in a 1 to 1 drug, 1.5 to 2 drugs. This is clearly a 2 to 3 drug procedure for most patients, maybe even a 4 drug procedure for some, if you're fortunate. And the beauty is you protect against so many of the downside adverse events that we have with a standard trab. We have not done a standard trab in the office that I'm aware of. I haven't seen the patient. My partner and I have talked about it. He admits that we haven't done one, probably 3 to 4 years. We've been using this device. And the beauty here is it doesn't offer a large bed or a large bleb. So if you need to put in a second one, you just move it over and do it someplace else, and you can occupy more tissue because it doesn't have that large area up top that sort of occupies most of the superior limbal margin from 2 o'clock over to 10 o'clock or maybe even further. The other thing that this doesn't do, and I can assure you of this because I've had probably 100+ patients who have had it done to mine that I've seen in the office over the years, you get almost no corneal dysesthesia, which is that horrible postoperative foreign body sensation. If you have a cornea like this, you have a bleb on top of it that's this big. When the lid passes over the bleb, it's not touching the eye at all, and you get this delum down here in this space right there. That's a bad look. That's tough. The blebs usually have to go back and be revised. They have to get flattened. Then they may not be as effective. With this device, you have a flatter bleb. The price you pay in exchange for that is that you also have a higher rate of revision of the bleb area. So in a standard trab, I'd say less than 10% easily, maybe 5%. Studies I've read vary in that range. Here, probably more like 1 out of 5. are going to need revised at some point. What I mean by that is the bleb actually fails. The bleb fails by flattening, and the pressure starts to go up. So you're seeing the patient post-op, and they're back in your practice and doing well. And about they usually tend to fail between 3 and 6 months if they're going to. And the patient will walk in, and the pressure was about 12, 13, great pressure. Now it's 18 or 19. And the patients are on steroids. You want to try to maintain the bleb. So it's usually not, if you have a tube in the eye, steroids usually don't raise pressure. If they raise it, the tube just evacuates more fluid. So in this case, if the pressure is going up, it's usually not because of steroid. It's instead because the bleb itself is flattening and compressing and fibrosing. So what we'll do is go in, take a needle, 27 gauge usually, go in and go underneath the conch, numb it up with some lidocaine, go underneath the conch, and sweep it and open it, and then subsequently inject it with either mitomycin or 5-FU, fluorouracil. And both of those are anti-metabolites that will keep it from scarring again. Sometimes patients are just scars. There's no way around it. Then you have to go to something else. But the vast majority of patients who do this, I can count on getting at least 2 good meds and usually closer to 3. This is a study that was done, it's been about, it's on the release of the product, so probably about clinical trial, maybe about 3 to 4 years ago. This study was interesting. This is a summary of the patients who were refractory. All right, so they were refractory and primary glaucoma. So refractory means no matter what you've tried, it wasn't working. And I want you to look at this. There's an initial massive drop on day 1. It's just not unexpected. You get a little bit of hypotony. Eventually that pops back up. And then in this study, and what we see is that over time, that product, that the actual outcome becomes quite positive, and the patient ends up going down and down and down, slowly, but very, very predictably, to the point where at 3 years out, we're looking at 37% reduction from baseline, which is unbelievable in a group of patients who were not responsive to anything else. So I do love this product as well, and I think it's something we like. And let me just show you this video, and we will finish this up and arrive right on time. So this is simply a scaffold to hold it. There's the inserter, goes cross chamber. You penetrate through the trabeculum. You're going to go up into the subconjunctival space. You've marked it on the outside, so you kind of know you're watching. You can see the needle right there. It's up into the subconjunctival space. You want it above Timmins capsule so you can get that separation. You're going to place the device, and then you're going to withdraw the needle eventually. It's starting to do that right now. It's getting the device nicely placed and finding his little sweet spot. And eventually he'll just pull the needle back and the device is there. You can usually see this with the slit lamp right up close to its edge. As I showed you earlier, about 2 millimeters is in the AC. An equal amount is in the sclera, going through the sclera. This is a transscleral procedure. And you go up and you rise up, and about 3 millimeters will be up under the subconjunctival space. You can see that this is actively filtering because you see those pockets of fluid. Those pockets of fluid will rise up. They will eventually penetrate through the surface, and they'll become tears in the eye and go back down the lacrimal canal into the nose and just go through the whole system again. So with that said, we have reached the 10:15 point exactly. And I am delighted to have been able to join you. I'm going to go back to this slide so Dr. Wu can introduce our next speaker for her program. So I'm very excited for that. I look forward to listening to that one. And Stephanie and everybody that was involved, thank you so much for the technical support. This was a pleasure. Stephanie, you're back on.
Great. Well, thanks for all those updates. I wrote down like a million notes because I didn't even know like a lot of this technology existed. So thanks so much